Achalasia cardia. Achalasia cardia is a rare esophageal motility disorder characterized by the failure of the lower esophageal sphincter, S, to relax adequately during swallowing and loss of esophageal peristalsis. It results in impaired food transit from the esophagus to the stomach. Etiology. The exact cause of achalasia is unknown, but the following factors are implicated. 1. Idiopathic. Most cases are of unknown origin. 2. Autoimmune. Immune-mediated destruction of inhibitory neurons in the myenteric plexus, Auerbach's plexus, is suspected. 3. Infectious. Viral infections like herpes simplex virus or Chagas disease, caused by Trypanosoma cruzi, can lead to neuronal damage in endemic areas. 4. Genetic. Familial clustering in some cases suggests a genetic predisposition. Pathology. Loss of inhibitory ganglion cells in the myenteric plexus results in impaired relaxation of the LES and loss of esophageal peristalsis. The esophagus becomes dilated proximal to the LES with progressive thinning of the esophageal wall. Chronic stasis of food in the esophagus can lead to inflammation, ulceration, and in rare cases, squamous cell carcinoma. Clinical features. 1. Dysphagia. Both for solids and liquids, non-progressive and worsens gradually, often the first symptom. 2. Regurgitation, undigested food or saliva, especially at night or when lying down. 3. Chest pain, retrosternal discomfort due to esophageal distension or spasms. 4. Weight loss due to reduced food intake and malnutrition. 5. Heartburn, misinterpreted as gastroesophageal reflux disease, GERD. 6. Aspiration, can lead to recurrent respiratory infections or pneumonia. Investigations. 1. Esophageal manometry, gold standard, shows absence of peristalsis and incomplete LES relaxation. 2. Barium swallow, shows a bird beak appearance at the gastroesophageal junction and dilated esophagus proximally. 3. Endoscopy, rules out malignancy or other structural causes of dysphagia, e.g., esophageal cancer or strictures. 4. Chest X-ray, may show a widened mediastinum or air fluid levels in the esophagus. 5. High-resolution manometry, HRM, differentiates achalasia subtypes, type 1, type 2, and type 3, based on motility patterns. Treatment. The primary goal of treatment is to reduce LES pressure and facilitate esophageal emptying. Management includes non-surgical treatments. 1. Pharmacologic therapy. Calcium channel blockers, e.g. nifedipine, or nitrates to relax the LES, limited effectiveness, and often reserved for patients unfit for other therapies. 2. Botulinum toxin injection, directly injected into the LES to inhibit acetylcholine release. Short-term relief, but repeated injections may be needed. 3. Endoscopic pneumatic dilatation. Balloon inflation disrupts LES muscle fibers. Effective in about 70% 80% of cases, but carries a risk of esophageal perforation. Surgical treatments. 1. Heller's myotomy, laparoscopic procedure to cut the LS muscle fibers, often combined with fundoplication to prevent reflux. 2. Peroral endoscopic myotomy, a minimally invasive endoscopic alternative to Heller's myotomy, effective in all subtypes of achalasia, especially type 3. Other measures. 1. Dietary modifications, soft or liquid diet and eating slowly. 2. Esophagectomy, reserved for end-stage achalasia with massive esophageal dilation, megaesophagus, or refractory cases. Complications: aspiration pneumonia due to regurgitation and aspiration, esophageal perforation, post-treatment complication, e.g. pneumatic dilation, squamous cell carcinoma, long-standing achalasia increases the risk, esophageal diverticula due to increased intraluminal pressure. Prognosis: with appropriate treatment, most patients achieve significant symptom relief. Regular follow-up is essential to monitor for complications, especially malignancy in long-standing cases.